Be any minute now. We'll usually give people a minute or two to catch up with us. It is Friday. It's been a long week, so
yes,
for everyone. But make sure it's all shared out the way it's supposed to be.
Mm-hmm.
All right. And once I'm sure of that, we'll get it up so I can see any comments that people are leaving us. Questions, comments, concerns. There we go. And it does look like we are up and we are running live.
Great.
Yeah. Yeah, it's amazing how quickly everybody learned how to use Zoom. A program that nobody had heard about in February, and all of a sudden, like by June, everybody knows everything about it. Okay, so I'd like to go ahead and welcome everyone to our Live at 5 program this week. We have a very special guest with us today, and that is Kyle Dalton from the National Museum of Civil War Medicine up in Maryland. So today's topic will be medical care, and specifically kind of focusing in the wake of the Battle of Second Manassas, so the late summer of 1862 and going into the Maryland campaign in September of 1862. You know, the Civil War represents a watershed moment in the history of battlefield medicine and American medical care. This is a time when doctors on both sides of the conflict are facing absolutely unprecedented numbers of wounded and sick individuals. And so just creating a system to care for all of those people was essential for victory. And so Kyle is going to tell us a little bit more about that. Now, anyone watching at home, please let us know if you have any questions or any things you'd like to learn more about. You know, just go ahead and put them in the Facebook comments, and I'll be sure to keep an eye on that as we move along. Now, Kyle, I've noticed you're drinking something today. It is kind of a happy hour. What do you got there?
This is a
excellent choice. I think a lot of our viewers will appreciate that. So let's go ahead and begin. So the American Civil War begins the spring of 1861. Is there any sort of medical infrastructure for the United States military at that time? What are we looking at the beginning of the war in terms of care for wounded men?
There is a medical system in place. There's a medical department. It is pretty successful for what it's doing, but what it's doing before the war is quite different from what it's doing during the war. Just read a piece that Jake Wynn from our museum, from the National Museum of Civil War Medicine, dug up by a hospital steward. And he talks about the Mormon Rebellion in the 1850s. He talks about campaigns against the Indians in the West. And he's a hospital steward through all of that. And he says he doesn't actually see combat until the Civil War. Now, probably he did see some combat, especially against the Indians, but he didn't consider that combat. It's very different. It's a much smaller scale. These aren't large scale battles. They're not conventional. So there is a system that exists, but it's meant for this much smaller series of conflicts. And it is meant for the West. It is meant for outside of civilization. So when it comes to the Civil War, they do have a system in place, but it is not designed for what they're headed into. And most of the medical establishment really doesn't understand what they're getting into. This goes both for trauma care, for combat, and for disease and disease control. The numbers that you're dealing with out west are much, much smaller. These are much smaller Army units. They're not the massed bodies of people that you have in the East during the Civil War. So there isn't much of an emphasis at the beginning of the war in the Army of either side on screening those soldiers, in ensuring that they aren't bringing disease to combat. There is a preoccupation with, can they fight? Physically, can you march? Can you tear the cartridge? Can you carry this stuff? There's a big focus on that, but not, are you going to carry malaria to the camps? Have you already had smallpox? There isn't as much of an emphasis on that. Now, I did say the Army specifically, because that's not true of the Navy. The Navy is an interesting counter example to this. because in the Navy, disease is actually pretty low. There are almost as many people who die from combat as die from disease. And in the Army, it's totally different. You are twice as likely to die of disease as to become a combat casualty. So it is a very different experience between the Navy and the Army. But most of the numbers that we're looking at in the East are going to the Army anyway. The Navy is fairly small in population.
So, with the first Battle of Manassas, the first Battle of Bull Run in the summer of 1861, this is really the first, I guess you'd say, mass casualty event of the war, the first real large-scale battle. What is that experience like in terms of the aftermath of the battle?
Chaotic. It's incredibly chaotic. Like everything around First Manassas, it is super chaos. So part of the problem for this is that because the Army was designed for Western, much smaller scale campaigns, they don't really have systems of evacuation. The battles that you're fighting out West, when they are battles and not just skirmishes, are short. They're very short and they're isolated. And so it's pretty easy to pick up your wounded afterward. You don't really need a system in place for that. The numbers are small, the battles are short. But in the East, of course, these battles can go for a very long time, and you might not be holding the field afterward. And if you're not holding the field afterward, your wounded are just left behind. They do know, and this is apparent in their military manuals, that you have to, if you have to operate, you need to operate sooner than later. Samuel D. Gross writes this in the Manual of Military Surgery for the Union, and John Julian Chisholm, I always get his name wrong, he says the same thing for the Manual of Military Surgery for the Confederacy. You've got to operate soon, get them off the field. And there's just not a system in place for that. Those ambulances they do have are designed, again, for Western campaigns. They're two-wheeled, which means they bounce around a lot. If you're trying to get them on these roads, they don't have a lot of suspension. They're really bad for trauma patients. In the West, you wanted two wheels because there's not a lot of roads. You got to be able to move around. But here in the East, it didn't work out. These patients were suffering horribly in the ambulances. And that's if the ambulances got to them at all. Through 1862, there's basically no force, north or south, where the ambulances are controlled by the medical department. They're controlled largely by the quartermaster. The quartermaster can use that for transporting ammunition. He can use that for moving troops. He can use that for a lot of things you shouldn't be using ambulances for. That converts them to legitimate military targets. If you see an ambulance rushing toward the front.
I didn't think of that, but yeah.
I mean,
if you're hauling ammunition, that is
a legitimate target. You should shoot at that. They're going to try to kill you. So by converting them from non-combatant to combatant, they confuse the whole system. And beyond that, if you're moving troops, if you're moving ammunition, you're not moving wounded, and the wounded get left behind. There is a prioritization pre-war and in the early years of the war on both sides that the wounded come second. You don't deal with the wounded, you come back to them. And PGT Beauregard writes this in his general orders leading up to the Battle of Bull Run, orders that he so thoroughly believes in. He repeats them every single year of the war. Whatever command he goes to, he sends these orders back out again. And they say explicitly that their number one priority is victory. Our greatest priority is victory. And because of that, they need to focus on fighting. They can't focus on the wounded. Leave them behind, keep fighting. We can deal with them if we keep the field. If we don't keep the field, they're in trouble. So fight to win, because that's how we're going to help these guys. To back that up, he also doesn't want to move any soldiers off the line that are good at fighting. So he says that the infirmary corps, the guys meant to evacuate the wounded, must be the least effective under arms. That's a direct quote. The least effective under arms. So it's all the bozos, and they're the ones that are going to carry you off if you've been shot through the arm. It's not a great system for the wounded. Arguably, it's not a great system for victory. But it's what both sides pretty much believe in at both First and Second Manassas.
Now, in terms of, I guess in terms of numbers of, say, like trained surgeons, trained doctors, medical men who are actually serving in these capacities in 1861 and 62, what are we looking at, like ballpark?
Ooh, that's a good question that I was not prepared for.
Okay.
I don't know the numbers offhand. If they are, well, I think the first thing is that all doctors are surgeons in the minds of the military. If you are in the medical department, you are a surgeon or an assistant surgeon or a contract surgeon. Surgeon and assistant surgeon are ranks. A contract surgeon can be either one of those ranks, but they're not officially a commissioned officer. They're contracted by the Army. It's really a pedantic argument. They still wear uniforms. They do all the same stuff. They still have to follow military hierarchy. It's again, kind of a pedantic thing. But Army doctors before the war aren't that much different from surgeons in the general populace. 9 out of every 10 Army doctors before the war had never treated a gunshot wound. So just being in the military doesn't mean you're prepared for trauma care, especially trauma care on this scale. There are significant numbers. They bring in a whole bunch of them. Yeah, I don't have the exact numbers on that, I'm afraid.
And what about training? What kind of training do these surgeons generally have before going into combat?
Medical school. There are at least 2 years of medical school required. It is a little bit different. There's, sorry, a couple of people outside waving at me. I guess they recognize the famous kitchen. So the training they receive is medical school. It's civilian medical school, and it's 2 years. Medical school back then is not the same as medical school today. I mean, first of all, in length, obviously, but there's also a wealth requirement. You have to buy tickets to your lectures. So there aren't a lot of poor people getting into this. And that's one of the reasons that there's also a racial barrier. There are not very many African-American doctors in this period. There are 13 that serve in the Union as surgeons by the end of the war, at least 13. But again, that's compared to however many doctors there are that I don't have numbers of, hundreds, certainly. And this lecture that you attend is very passive. It's not hands-on. You're not getting involved in it. You're watching entirely. You're in a surgical theater, usually, and you may be watching a demonstration as it goes along. You are expected to get some hands-on practice. Maybe you volunteer to help out the professor, who himself is a trained surgeon. You're expected to help people who come to the school sometimes, depending on the school. They get free medical care, but they're being treated by students. So that's one way that you can learn, but it is much more passive than medical education today. It's much more hands-off. It's much more bookish. So they are trained. They do know what they're talking about. And most of the techniques, the surgical techniques, the X's and Y's, the movements, the kind of tools you use, aren't that different from how we do it today. It's just the fact they're not getting the hands-on experience doing it. And a couple of things that we know now they didn't know back then, like germ theory.
Yeah, that's a big one.
That's the biggest one.
The big one. Okay, so, in the aftermath of these early battles of the war, it's, like you said, absolutely chaotic. There's no real system in place for dealing with this. When does that begin to change? When do we see a transition?
Well, it's an uneven transition. We do have a transition, but it's not universal. It's haphazard, it's scattered kind of throughout the war, and it starts right after Second Manassas, which is really bad news for the people of Second Manassas. It unfortunately doesn't change that much for the first year of the war. From First Manassas to Second, it's a little bit more organized, but there's still a lot of chaos out there. There's still a lot of disorganization, and it's not until Antietam, really, that it changes. And again, even then, there's still a lot of caveats to that. So the Army of the Potomac in 1862, after the Battle of Second Manassas, they institute something called the Letterman System. This is what we today call a chain of survival. Modern military medical professionals call it the chain of survival. And that is what's done from the moment you're wounded until the moment you're discharged. Today, it extends beyond that with a VA and other systems. Back then, it was till you're discharged. So this chain of survival, again, a modern term, goes in place when Dr. Letterman, Dr. Jonathan Letterman, he's the medical director of the Army of the Potomac, creates a systematized method for moving the wounded safely as possible, and triage. The first step is getting them off the field. To do that, he institutes the ambulance corps. That's my specialty. I really dig the ambulances and stretchers and stuff. And the ambulance corps makes up as much as 3% of the Army of the Potomac by the Battle of Gettysburg. It is possibly that big. It's a little hard to tell. The numbers are a little wonky, and a lot of them don't wear insignia. So you can't really tell from photographs either who is and who is not. Very few surviving garments from this unit exist. But it could be thousands of people. And once you're taken off the field, then you receive treatment. And that's done at a field dressing station. This is broken up at the regimental level. And unlike what happens at 1st Manassas, and I think even at 2nd Manassas, you can't be turned away from field dressing stations that belong to another regiment. Whoever's closest to you, they can take you. And they're scattered and set throughout the field so that no one gets overwhelmed if they just happen to be closer to combat. When you get to the field dressing station, first aid happens. That's where the bandaging happens, maybe minor surgery, but probably not. You get pain management, lots of opioids, maybe a stimulant to keep you awake, like whiskey, that's a big one. And I'm not sure if they applied anesthesia here, but they may have. They would then load you onto an ambulance if you weren't already on one, and they would send you back to the field hospital. The field hospital is where the surgery happens. That's where all the amputations take place. This could be a tent hospital. It was often in barns like Pry House, one of our locations on Antietam National Battlefield, which is definitely worth a look. Or a house. There are many houses that are converted, sometimes churches if they're close to the battlefield. Once you've been processed through the field hospital, and sometimes people would recover there for quite some time, they would send you to a general hospital. The general hospital is in a city like Frederick, our main location. Frederick, I think, had like 40 hospitals in it. It's one of many cities that's referred to as one vast hospital. Washington, D.C., Wheeling, West Virginia, Alexandria, Virginia, all of these cities and many more are just filled with hospitals. And these are meant for long-term care. This is where Mercy Street takes place. If you ever saw the ultimately.
Oh, yeah.
So that's the chain of survival. It's you have stages that you pass through from the moment you're wounded until the moment you're discharged. And that's the Letterman system.
So, the Letterman system, does that only apply to the Army of the Potomac? Is this in use in other federal armies? And what about the Confederate Army? What are they doing? How do they adapt?
That gets back to what I was saying earlier. This is not universal. It is only the Army of the Potomac at first. Only the Army of the Potomac in 1862 sees this. It is not applied to the Western armies. The Confederacy doesn't institute anything like this throughout the war. They do make their own attempts at innovation, but nothing as systemic or wide scale as this. I don't mean to diminish what they did, because their general hospitals were amazing. Chimborazo in Richmond was the largest hospital in the hemisphere, but there wasn't the same effort to get people off the field, and that's a big one. If you were a wounded Confederate, you had an 18% mortality rate. If you were a wounded Union soldier, it was a 14% mortality rate. So that may seem like a small percentage, but it's huge numbers we're dealing with. So the Confederacy, because they don't make the effort to evacuate, that's a big problem. They also don't systematize their field hospitals in quite the same way. They still do, but not as thoroughly. That has an effect as well. Hospitals can get overrun because they're not being placed quite as carefully as in the Letterman system. And again, that goes back to what P.G.T. Beauregard said every year of the war. The effort is victory. And this is still a debate in military ethics. How important is the survival of the individual wounded soldier, or in this case, thousands of wounded soldiers, over are we going to lose this war and make it worthless? It's not a debate that's settled even today. Now, in the North, they do eventually systematize the Letterman system across all armies. This starts in 1864 with the Ambulance Corps Act. It's just that one part of the Letterman system that you have those guys trained to safely evacuate people off the field. But that's what really kicks it into high gear, because that sort of cascades into everything else. The field dressing station, the field hospitals, the method of triage. And by that point, they'd also instituted other reforms like boards of inquiry to ensure that surgeons were doing what they were supposed to be doing, or that they weren't quacks that just came in because they were country doctors following their town's regiment off to the field. So it does kind of come together, but even then, this is such a massive conflict. It's so huge that the Union still doesn't quite pull it off entirely. Henry Billings, who writes Hardtack and Coffee, very well-known Civil War book, he says that the one order that was ignored the most in the entire war was the order that only the ambulance corps could evacuate people off the field. He said everyone ignored that order. There's an ambulance corps captain that complains that there were regimental commanders that didn't even know the ambulance corps existed, which was probably them lying to avoid doing stuff. But nonetheless, it's just not as broad brush as we think it is. It was big. It did make a difference. We inherited that system. And it's not to diminish how important it is, but this is a huge conflict. You just can't get that many people off the field safely, period. Just can't happen. And so they relied on drummer boys till the end. They relied on volunteers, civilian volunteers. That guys were being dragged off the field by their buddies. It continued to happen to the end of the war, both North and South. It's just there was also this system that was meant to get people off the field that did very well when you were able to get to it.
We do have a question right now. Someone is asking how many soldiers per ambulance wagon?
Per ambulance wagon, 3. You had your driver and 2 stretcher bearers. It's a little unclear to me where the stretcher bearers rode. After you loaded the wounded, they just stay behind? I'm unclear on that.
How many wounded per wagon are we?
Depended on the wagon. There are many models of ambulance wagon. Beginning of the war, again, there's a lot of 2-wheeled ambulances. They ditched those almost immediately. After that, there's a lot of 4-wheeled models. There's the Coolidge, the Wheeling, which is also called the Rosecrans, the Rucker. There's a whole bunch of them. The Langer is another one. There's lots of great photos of that at the Library Company of Philadelphia. This company producing the Langer ambulance was trying to get a government contract, and has a lot of people modeling with it. So there's a lot of different models of ambulance wagon, and the numbers varied based on which one you were using, and also what type of wounded you were carrying. If your wounded had to be laying down, you would carry less, which seems obvious. But almost all of these models were meant to have the seats fold up and create double or triple layer of beds. So you could keep loading people on top of each other like bunk beds. So it's a huge range of people, depends on what wagon you're getting loaded into. For the Confederacy, they make no real effort to build a lot of ambulance wagons. They capture a lot of them. There's no orders that come out for it. I don't know that they prioritized capturing ambulances, but an ambulance would be a prize. That's something you would want to capture as a rebel. So there's no real effort on their part to do it, and they sometimes sequester just plain old wagons. Ambulances are built to move wounded people. Wagons are not. Ambulances are still terrible to ride in. There are many accounts, I can think of half a dozen, where soldiers who are wounded beg to be left on the side of the road to die instead of being carried back to the hospital. They were incredibly uncomfortable, and they had huge springs to try and compensate for that. Now imagine not having any of those springs, having no balance at all, going along these very rough roads in the back of just a flatbed wagon. It must have been an excruciating experience for wounded Confederate soldiers. And that's if you got off the field at all. I mentioned earlier that the Union makes the effort to systematize, the South does not. There are a couple of instances. There's a small company called the Infirmary Corps out of Richmond. It's only 50 guys, and they're never at full strength. There's a lot of desertion. There's also the Richmond Ambulance Committee, which is made up of civilians, and they do a lot. They have 150 wagons, which is pretty good. Nothing compared to the Union, but it's pretty good for a civilian effort. But there's one account from a guy in Tennessee, and he's assigned to the infirmary corps 2 hours before the battle. No training, no experience, and they don't give him a stretcher. He just is supposed to drag these guys off the field. His lieutenant gets a cannonball through the hip, and he's just supposed to haul this guy away. So again, there's not the same priority in the South that there is in the North, and it does have an effect on the mortality rate.
Another question, we've got a question about what type of anesthesia would be available to these men. Now, you mentioned that would be something that would come in when they're back at they've gone through the field dressing station, they're back at the field hospital where these surgeries are taking place. So what are they using? There
are two main types in the period. Nitrous oxide exists, but nobody's really using it. It's instead chloroform and ether. Ether is the first substance that is widely accepted as an anesthesia, as a general anesthesia, putting people to sleep. And that's demonstrated 1846, I think. And within like a few months, it's used in the Mexican War. So it immediately gets a military application.
Very cool.
It's straight away. And actually, the American surgeons appear to have passed it on to the Mexican surgeons. The earliest known photograph of an actual operation, not staged, but like they're holding the guy's bloody stump and he's passed out. There's American and Mexican surgeons together. It's after the Battle of Cerro Gordo. The Surgeon General of Santa Anna's army is the guy doing the operation. It's a pretty astounding.
That's wild.
Yeah, it's super cool. And they're using ether. Now, the problem with ether, though, is that it is explosive. It catches fire like crazy. In the 1920s, they did an experiment and found that if it was 20 feet from the source of heat, it would still catch fire. It's very dangerous to use. So
you can see how you would not want that on a battlefield.
Exactly. Yeah. You don't even want to carry that with your wagon train. It's bouncing around. People are smoking. So ether is used. It's used mostly in general hospitals. So that's the last stage of the Letterman system, the last stage of the chain of survival. It's just much easier and safer to control it there. And it does. It's also one of the reasons chloroform is preferred over that. On top of it not exploding, is that it works faster. Chloroform puts you to sleep faster, and it uses less. This is especially important for the Southern troops. Sure. Anesthesia is still widely used. I actually have not yet found a surgical operation in the South where they didn't use anesthesia. And in the North, out of 60,000 plus surgeries, probably way more than that, only 250 cases where anesthesia was not used. So it's well below 1% of surgery.
I feel sorry for that, one of those 250.
Yeah. And none of the surgeons explain themselves either as to why they're not using anesthesia. The medical department in a report years later, I think a decade or two later, says that maybe these surgeons thought that like it would create hemorrhaging or something, like maybe it poison the blood. Maybe they thought that, but they sort of dismissed that out of hand of like, this is a ridiculous belief. Like we've been using anesthesia for decades. It's silly. And very few operations have that happen. They're almost always extreme circumstances. For example, there's a soldier in the 1st U.S. Sharpshooters who's captured in Northern Virginia. I don't remember which battle, but it's probably your heritage area. And he's captured with 500 other wounded soldiers. And the Confederacy leaves only one captured Union surgeon with one assistant to care for all of them. So this guy has to do 500 amputations by himself. And it's, I think, 3 or 4 days before this guy gets his amputation. And there's no anesthesia left. There's no quinine, there's no opium, just cut straight into this poor guy. It's, again, a very unusual circumstance. You don't run into that very often. But anesthesia is widely used. Chloroform is number 1, ether is number 2.
Okay. Another great question just came in, asking if ambulances carried medical supplies and did they do any work on the injured people, I guess, while they're in the ambulance, or were they just mechanisms to get someone to the hospital?
Good question. And the common sense answer would be, yeah, of course they would. But the actual answer is no, they didn't carry any medical equipment to the field. They could be used to carry them on march. You see this often written about in personal memoirs and orders. They're carrying medicines back and forth. But when they go onto the field, they are only to remove the soldiers. They're only there to remove the patients. They are not intended to do any first aid. And this is a big difference between North and South. Now, so far, I've kind of made the South sound like it was super backward. And in some ways, the Confederate Medical Corps wasn't innovating in the way that the Union was. But when it came to first aid care, when the Confederacy thought about it, they did much better than the Union did. The infirmary corps I mentioned earlier, the 50 guys who went out to the field, they were trained to bandage wounds. They were trained to stop bleeding. They were trained to do what we would think of as combat medic stuff. They're in the line of fire and they're doing the bandaging. These are the guys at the beginning of Saving Private Ryan who are trying to stop the bleeding while the bullets are flying around them. That didn't really happen in the North. There's a case of a hospital steward who writes about being pretty near the fight, like hearing the bullets, seeing the bullets, being really close to combat. And he writes afterward that that was a really stupid idea. He really didn't want to be there. And his justification for this, for not doing battlefield first aid, is, well, either they're going to bleed out or the bullet will stop the bleeding. That's like, yeah, that's not really true.
I'm not sure that's how that works. I'm no doctor, but.
Right. So the ambulance corpsmen, the guys who are carrying the stretchers, the guys who are driving the ambulances, they're not trained in first aid. And even PGT Beauregard, where he's like, hey, we're going to send the losers up front, the least effective underarms, he says they should be trained in bandaging, that they should be trained in stopping bleeding. So they don't really care about evacuation, but if it's going to happen, they're going to do first aid. It's a weird division between North and South.
That's very interesting, yeah.
The North doesn't, the North systematizes and has this huge effort, thousands of people involved, but they're not trained to actually stop the bleeding. And in the South, they've got, a few hundred guys, but they are trained to stop the bleeding. It's so strange to have these very different approaches, both of which have obvious common sense gaps. And that's what comes with studying history, is that things that are obvious to us today, things that are common sense, just didn't occur to them back then.
Right. Why no one thought to put those two things together.
Chocolate and peanut butter, yeah.
Right. Got a question about designations on ambulances. What showed that this was an ambulance versus an ammunition wagon or some other sort of transport? What kind of designations did these ambulance corps guys wear, or the Confederate medical combat medics? What did they wear? What showed that these guys were doctors?
I actually just wrote an article on this for our journal, The Surgeon's Call. If you become a member at the National Museum of Civil War Medicine, you get a subscription to The Surgeon's Call, and we'll send you the latest issue. So if anybody's interested in seeing it, become a member, support us. But it's the short answer to that is there's no system that everyone agrees on. There's no color, there's no insignia, there's no flag that everybody agrees this means medical, don't shoot at me. It varies based on armies, it varies based on time, and a lot of people just gave up. A lot of people just didn't wear insignia. That's one of the reasons that ambulance corps uniforms basically don't survive, is a lot of these guys didn't wear the stuff. There doesn't appear to be, I have not found any evidence that either army made any effort to tell the other army, this is what medical staff is wearing. Specifically the non-combatants, the non-combatant private men and non-commissioned officers. There is sort of a uniform agreement that if a guy is wearing a green sash, he's a surgeon and therefore should not be shot. The green sash is universal. That is the one thing everybody agrees on, but it's only surgeons. There are a couple of photographs of hospital stewards in the North wearing green sashes. That's not what the regulations call for. They call for a red sash. They may have worn the green sash because it was so widely recognized as non-combatant. This actually applies to Second Bull Run. There's a really telling case here, and it's wild. Dr. Calvin Cutter, he's the 21st Massachusetts. He's a surgeon.
Good name for a surgeon, Dr. Cutter.
Yeah, I think he's the brigade surgeon there. And he's got a wild life. He rides with John Brown before the war. There's some pretty crazy stuff that goes on there. But at 2nd Manassas, he sees his regiment breaking and he draws his sword and rallies them. And he actually goes into combat, which is a no-no. That is a non-combatant doing a combatant thing. Don't do that. So he charges into the fight, and he gets subdued. He gets shot in the belt buckle, knocked to the ground. You always hear about people getting shot in the belt buckle, but apparently this one actually happened. And a rebel comes up, a rebel soldier, and tries to run him through with his bayonet. And the doctor goes, "No, wait, I'm a surgeon. Don't kill me." He's like, you just tried to kill that guy. I'm pretty sure he'd be in his rights. So the soldier hesitates, and he's like, "You've got a sword in your hand. You're fighting us." An officer rides along, and the officer sees the green sash and says, "That's a surgeon. You can't touch him." That is the one thing that everybody agrees on. That's non-combatant. You can't touch it. Even this guy, sword in hand, leading troops, he gets spared because he's got the green sash. But it's the only one. There is a myriad system, I wouldn't even call it a system, chaos of insignia, north and south. So in the Army of the James, their ambulance men wear a red band around the hat with a knot on one side and a red stripe on each arm. The ambulance corps in 1862 wears a green stripe on each arm and a green stripe around the hat. I got an example here. So again, sort of trying to evoke that green sash. But the infirmary corps, those 50 dudes out of Richmond, wore a gray kepi with a yellow stripe and a dark blue frock and dark blue trousers. There were other ambulance men, north and south, that wore a white stripe around each arm. There's badges that are handed out in the Army of Northern Virginia, red badges that have the words ambulance corps across them. But they don't wear any arm insignia. There's also an excellent piece in Don Troiani's collection from an ambulance man named A.C. Brigham. I think he's out of the Northeast. I think he's a New Englander. And it's just a rectangle of fabric. It's red with a green border. And along with that badge came a handwritten note by A.C. Brigham himself that says, "This was the badge I wore in the ambulance service. They did not seem to respect it much." So presumably nobody knew what it was supposed to mean, and they kept shooting at it. It was such a chaotic system, and almost all of those have some equivalent in the color system used by combatants. The red being artillery, the yellow being cavalry, the green, sometimes rifle companies wore green insignia. So there's no real effort to get that insignia across. The same is kind of true of ambulances. We have a photo album on our Facebook page, National Museum of Civil War Medicine, that is ambulance insignia of the Union. Again, there's not as much of an effort in the South, and I haven't found any photos of Southern ambulances. There's one sketch in the medical and surgical history, but there's a lot of photos of Union ambulances. And they've got like corps badges on them. Sometimes they have ambulance in it in big letters. Sometimes it's just the regimental number. A lot of ambulances had no insignia. Some of them flew little flags. Those might be red. They might be yellow, bordered in green. It was chaos. There was no real effort to make one thing everybody agreed on. There's no Red Cross in this period. And that leads to a lot of casualties. A lot of ambulance men are killed because nobody knows who they are.
Yeah, I was just going to ask, it sounds fairly dangerous. I mean, I looked at that hat you just pulled up, and from 200 yards away, you can't tell what that is. So that's interesting. Now, moving forward kind of out of the Civil War, what is the legacy that comes out of all this? What is the lasting impression that this is going to leave on combat medicine or on military medicine?
Well, in the immediate aftermath, in the first couple of decades, the innovations that Letterman put in place are continued in military medicine. I would argue that we are actually somewhat ahead of the European powers when World War I comes around. There are ambulances that are sent across to expositions throughout Europe to demonstrate the advances that Americans made in battlefield evacuation and triage. The main model of stretcher and main model of ambulance, the Halstead stretcher and the Rucker ambulance, the ones that were most popular in the North, continue in service through the Spanish-American War. So for decades, those are the standard issue evacuation gear. For trauma care, the surgeons of the Civil War in the North send case studies back to Washington, D.C. Case study after, there's thousands of these. There's 3,000 pages in the medical and surgical history of the War of the Rebellion. The medical and surgical history is just, I don't know how many words, but again, 3,000 pages, densely packed, double column, single spaced, small type. And it is a wealth of information. These case studies were often accompanied by specimens. So I was recently at the National Museum of Health and Medicine, which is the descendant of the Army Medical Museum that was created during the war. And they just had shelves and shelves and boxes of excised limbs of just the top part of the arm. These were cut out. It was an alternative to amputation that might allow you to retain movement in the arm. And sometimes it worked. Sometimes these guys were actually able to keep using their arm just without the ball socket. And there are thousands of these at the Army Medical Museum, now the National Museum of Health and Medicine. So for education in trauma care, it was a huge leap forward. Anesthesia had already been pretty well applied. So there wasn't as much movement on that as we might think, because that was largely something people agreed on anyway. But when it came to the actual practice of surgery, we now had many, many case studies. We had countless surgeons who had experience in this. It really was a huge leap forward. And in the ambulance system, that was also bleeding through the civilian realm. The first two civilian ambulance systems were in Cleveland and New York, and both of them were founded by Army surgeons who worked in the ambulance corps. They just straight up picked it up and gave it to civilians. So the ambulances we see and use today are a direct benefit of the Civil War. We definitely have inherited the successes of the Army of the Potomac and at large the United States Army. We've also inherited some of the failures. And there were some ways in which we were set back a little bit by the war. I just recently wrote a piece that's going to go up on our website soon, civilwarmed.org, on germ theory. And in that, I argue that germ theory was set back in the United States by these surgeons. And that's not to condemn them. They were dealing with a lot of trauma. One surgeon writes that his hands were so covered in blood for so long that they wrinkled like a washerwoman's. They saw some really traumatic stuff, and they were rightly proud of the lives they did save. And then to tell them, oh, but actually you killed tens of thousands of people because you didn't wash enough between surgeries, which also implies that they're dirty people. That's a lot to swallow. And that pride and guilt, that kind of comes together and it galvanizes the American medical field against germ theory. It's these European upstarts who haven't seen what we've seen. They haven't saved lives the way we saved lives. And it makes them unwilling to accept it. And it takes Americans a lot longer to come around to germ theory than it does Europeans. So that's one way that we got set back a little bit by that.
I'm glad you mentioned that, because we just had a question about, did anyone recognize the causes of infection, or, how did they handle controlling infection? But, without germ theory, it was, I imagine, pretty difficult.
It was a guessing game. There were some successes. Bromide was used in the period. They didn't understand how it worked. And in fact, the surgeon who pioneered the use of it as a disinfectant didn't call it a disinfectant, didn't know what it did. All he knew was that it slowed and stopped the spread of hospital gangrene. So we should keep using it. And in his piece that is actually published by the Army Medical Department and distributed through surgeons, he says, it's best for us not to question why this works. It just works. Let's just do it. And he's not wrong. I mean, that did save lives. They don't really know what causes it. They don't really understand it. They do have some idea of contagion. They do understand that it can spread, that one person can get it if somebody else has it. And for that reason, some of the general hospital designs, those that weren't like seized churches or hotels or whatever, they were laid out in a wagon wheel pattern. You had wards that were set across, and then you'd have like railways or roads connecting them. And that was to separate the different kinds of patients. It stopped the spread of the contagion because only patients who already had it were in that ward. So there are efforts made to prevent the spread of disease. But because they don't know what causes it, there are a lot of gaps in that. There are a lot of ways that it can slip through. And one being, of course, disinfecting. They just have no real concept of it. They don't really understand how it works. In the Hospital Steward's Manual, written by J.J. Woodward, he says that the hospital steward should clean the tools. He should clean them very well. They should be shining. They should be sharp, but only when the surgeons were done with them. And when he says to clean the tools, he says that it's to be done to preserve the tools, to keep them sharp, to keep the handles that are wood from coming apart if they get too wet, to prevent rust, all of which are important, but it's not disinfecting. Hospitals, general hospitals were clean, but they weren't disinfecting. So again, that leads back to this rejection of germ theory. How can you tell us that we're filthy? We've made all this effort to stay as clean as we can. Clean bed sheets, we open the windows, we put nice potted plants out there, which, are not necessarily helping, but it does look and smell clean. It's just not disinfected. It's not stopping the spread of germs, and there's no way for them to have known that from 61 to 65.
Great. Well, I want to thank you so much for joining us today. Unless we have any more questions coming in, we'll give folks a minute or so to catch up. But before we do, here we go. Someone just asked a great question. You mentioned that there were not many African-American surgeons. What about female physicians or surgeons?
Good question. There were a couple.
Really?
Yeah, there were a couple of women doctors. The Civil War allowed women to break into the medical industry in a way that was difficult before the war. Not impossible. The women surgeons that I'm thinking of became doctors before the war. They didn't get their degree in 63 and then join the fight. The most radical, the most famous is Dr. Mary Walker. Dr. Mary Walker is to this day the only woman to receive the Medal of Honor. She was a contract surgeon. She was also a radical feminist. She wore a relatively short skirt. We're talking like mid-calf. It's the 1860s.
Yeah.
But she wore trousers beneath it. She had a mix of male and female garments. And she was, by all accounts, a very good surgeon. She crossed back and forth between the lines. Her role as a female surgeon meant she was less likely to be detained if she went south. There were some surgeons that were detained by both sides as the conflict went along. But she was able, both as a medical professional and a woman, to go back and forth between the lines with relatively little trouble. She did treat soldiers on the battlefield in field hospitals. And again, for her bravery, she was given the Medal of Honor. She's the most famous female surgeon. But most women served as nurses. This was also a way for women of color to break into the medical establishment. They didn't become doctors or surgeons. It was hard enough for an African-American or a woman, but an African-American woman was basically out of the question in Victorian America for going to med school. So instead, many of them became surgeons. Susie King Taylor being the most famous. Did someone just say Susie King Taylor?
Oh, no, you said surgeons, and I was like, nurses. Yeah.
Yes. Yeah, there were many female nurses during the war. Actually, Calvin Cutter, the famous surgeon from 2nd Manassas who leads troops in the battle, his daughter was a nurse, and she died. She got sick tending to other Massachusetts soldiers and died in North Carolina. She's the first woman to be buried in a national cemetery, I think. She was buried next to, there's a lot of stories out there, maybe her fiance, it's unclear. He may have also been one of the raiders on John Brown's raid of Harper's Ferry. It's a wild story. Anyway, there were a lot of women nurses during the war, as well as male nurses, Walt Whitman famously. But it was the avenue that allowed them to get into the medical establishment. It was the avenue that allowed them to break through. Few of them were able to break through in the way that Dr. Mary Walker did, but it did create a wider societal acceptance of women in the medical profession.
We do have a question. Did Mary Walker get to keep her Medal of Honor?
Yes and no. It was revoked after the war, decades after the war. Congress recognized that the Congressional Medal of Honor had been given out too frivolously, and that's not wrong. I'm not talking about Mary Walker, but there was like a whole regiment, I think from Ohio, that was called up last minute to defend DC, and they showed up and they got in the trenches. Rebels never showed up. They all went home, and the entire regiment got the Medal of Honor. That's not appropriate. That kind of diminishes the importance of it.
Right, absolutely, yeah.
But her Medal of Honor was revoked because she was a contract surgeon. I mentioned earlier that contract surgeons, they're still doing all the same stuff that assistant surgeons and full regimental surgeons are doing. They just have this caveat of not being a full-blown non-commissioned officer. They're or commissioned officer. They're commissioned officers that aren't commissioned. It's a silly, pedantic on that technicality. There were protests at the time against that. There were people who said this doesn't seem right to us. That seems pretty messed up. Other contract surgeons did get to keep their medals of honor. So it's clearly they were trying to do something else. And you couldn't really deny that Mary Walker did some amazing stuff in the war. It was in the 20th century, late 20th century, reinstated after her death. She never acknowledged that it was taken away. She saw it as a put-up job, and she continued to wear the Medal of Honor to the end of her days. But it has been reinstated. There have been some legal people who objected to that and said, like, oh, it diminishes it because she was a contract surgeon, blah, 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 whatever. She earned that medal. And to this day, the U.S. recognizes that she has that.
Wow. That's a wild story. I knew nothing about that. Well, we're almost out of time here. Thank you so much for joining us, Kyle. Thanks to everyone who was following along. A lot of great questions, a lot of great comments. Kyle, if people want to learn more, where should they go?
Well, your first stop might be our Frederick location, the National Museum of Civil War Medicine. We're on East Patrick Street. That's our main headquarters, and we just reopened today. If I've got bags under my eyes, it's because it's been a long day. We have just reopened. You can come by Friday, Saturday, or Sunday, or you can make an appointment any day of the week. We are practicing social distancing. We're staggering entry, so it's a good idea to make a reservation before you come in. We do require masks. We are a medical museum. We do have hand sanitizer. We have bathrooms with sinks you can wash up in, and we do sanitation every half hour. We go around the museum and we do all the handles and all the doors. We do all the countertops up front. We're doing everything we can to keep this as safe as possible. So if you want to come by Friday through Sunday, that's great. Otherwise, make an appointment. And if you want to support us, we are going to keep doing digital content on our own Facebook page and our YouTube channel. We are going to keep doing lectures. We bring on professionals, historians, authors, people who have some expertise in the field of Civil War medicine. And we do that about twice a week. That's going to continue even after quarantine lifts, even after we're fully open 7 days a week. So keep an eye out for that. Visit our website, civilwarmed.org. The best way that you can help us keep doing this is memberships. Membership gets you a lot of great benefits. Again, that Surgeon's Call Journal I mentioned earlier, get a free subscription as well as our newsletter. 10% off in our gift shop, a coupon for a purchase in the gift shop that's even better than that, discounted admission to special events, free admission to all 3 of our locations in DC and Maryland. So lots of great benefits for that. Check out our website, civilwarmed.org. That's the place I'd say to go.
And if you guys have not seen Kyle's cooking demo of Civil War substitute coffees, I do not envy you for having to drink some of those. Some of them sounded
a nightmare,
downright disgusting. But you know, look for that on the Civil War Medicine Museum's Facebook page because it is a riot. You know, just like the Medicine Museum, you know, the Mosby Heritage Area Association, we are beginning our transition kind of back to more openness. We'll have some more good details about what exactly that is going to entail next week. So please keep an eye on our website, mosbyheritagearea.org. Follow us on Facebook. As I said, we will be slowly transitioning back to more in-person events, but we will also keep virtual events like this going. There will not be a live at 5 next week. We're taking a day off or a week off to kind of plan for our transition, plan for some of these upcoming events. So again, keep an eye on our website and on our Facebook page for more details. We thank you guys for putting up with us for months of this online programming. I'm looking forward to a little break. But in the meantime, you know, take care of each other, stay safe, stay healthy, and hopefully we'll see you at some events soon. So thank you so much for joining us.
Thanks for having me.